Dr. Carmen Rasmussen and Katrina Kully-Martens will be presenting new and interesting information on the results from the Alberta pilot of the Treatment Improvement Protocol for FASD. Before I introduce Carmen and Katrina, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right-hand side of your screen. A session facilitator is monitoring the question and will post them at suitable times during the presentation. If you aren't able to answer all the questions during the live presentation, we will answer them via email after the session is over. It is important that you include your email address when you ask a question, otherwise we will have no way to send you an answer. The presenter's contact information will be found on the final slide of the presentation. In order to receive your certificate of attendance, you must have signed in after 8:45 a.m. Evaluations for the sessions will be emailed to you after the session. Please fill them out, and return them. We rely on your feedback to continually improve what we do and how we do it. Today's presentation and handouts will be posted for viewing and downloading on the Government of Alberta website, fasd.alberta.ca, within 2 weeks of today's date. If you experience any technical issues, please email support@cmgcanada.ca. Also, please let your local tech support your known problem, as it may originate at your end. As Alberta advances with the FASD 10-year strategic plan, education and training continue to play a key role. This is our 6th year of offering sessions and our 3rd year of delivering the materials as webinars. As always, all sessions are recorded and made available on the GOA website at fasd.alberta.ca. We are pleased with the ongoing interest and attendance in this initiative. And I have the pleasure of introducing Dr. Carmen Rasmussen and Katrina Kully-Martens. Carmen Rasmussen is an associate professor in the Department of Pediatrics at the University of Alberta and a CIHR new investigator. She is also a research affiliate at the Glen Rose Rehabilitation Hospital, where she has been conducting research into FASD for over 10 years. Dr. Rasmussen is the co-chair of the Evaluation and Research Council within the Government of Alberta and a member of the National FASD Demonstration Project funded through NeuroDevNet. Katrina Kully-Martens is a Vanier scholar and a PhD student in school and clinical child psychology at the University of Alberta. Jointly supervised by Dr. Carmen Rasmussen and Dr. Jacqueline Pye, Katrina's research primarily concerns the development, implementation, and evaluation of FASD prevention and intervention programs. Our clinical interests include psychological assessment and intervention for children with neurodevelopmental disorders and complex mental health concerns. Please join me in welcoming Carmen and Katrina.
Thank you very much. So as mentioned, I'm going to be speaking about an Alberta pilot project that we did here, assessing the treatment improvement protocol for fetal alcohol spectrum disorder. The research team is much larger than just Katrina and myself. It also consists of Jocelyn Cook from CanFASD and SOGC, as well as Sterling Claren, the previous director of CanFASD, Dorothy Badri, Hasu Rajani, Therese Grant from the University of Washington, and student Isabel Light at the University of Alberta. So I'm just going to start, and I'll go over some of the background on the TIP and why it was introduced, and then I'll talk a little bit about the Albertan or Canadian TIP, and then Katrina will come in and talk about some of the results from the screening project, and then we'll also talk about some of the results from the survey that we had providers do on the TIP, and then finally we'll end with some discussion and future directions for the TIP program. So, what is a treatment improvement protocol for FASD? The Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, I think that's how you pronounce it. They're a large website. You can Google it and find out a lot of information on it. They're based in the US, and they frequently publish tips for various things in substance abuse and mental health. So they recently published a tip. It's called the Treatment Improvement Protocol for FASD, but they have many other tips that they have published in the past. And they felt that it was timely to publish a tip related to FASD. And what the tip is it's basically like a change in practice. It's designed for service providers who are working in the substance abuse and or mental health fields. And it provides tools and a process for identification of individuals who either may have FASD themselves or may be at risk for having a child with FASD. So the overall goal of the TIP is to get a lot of these frontline agencies screening for either FASD or people who may be at risk for FASD, because a lot of those individuals are likely attending those service agencies. And then, of course, if they are screened for FASD, they may be referred to the appropriate diagnosis or service. So why did they specifically want to do a TIP for FASD? Well, we do know that there's very high rates of mental health problems, as high as 90% in FASD, as well as alcohol and drug problems in FASD. So a lot of these clients are likely already accessing mental health and substance abuse services, but may not be identified in those programs. Substance abuse and mental health agencies don't currently screen for FASD in intake, which is obviously really important if these individuals are accessing these programs, to screen for them and to offer to help with diagnosis. So it's really an important opportunity to implement brief, effective approaches to improve outcomes for individuals affected by FASD, as well as screen women who may be at risk for having a child with FASD. So the TIP is a very, very large document published on the SAMHSA website that I think anybody can go and get information on that. But there's also a Canadian version of the TIP that is published on the Canada FASD website, which is a much more condensed version and contains Canadian and Albertan information. But really, the goal of the TIP is to help educate service providers about FASD and provide tools, screening tools. So for the first part, for a woman who may be at risk for having a child with FASD, there are various screening tools that are recommended to use in the TIP. They're not required to use, but they're recommended. And these are just basic alcohol use screening tools that are quite popular, really short screening tools, things like the TASTE, the TWEAK, the CAGE, the CRAFT. But it also, they're not required to use these tests. So if substance abuse programs have existing tools that they are using already, they can use their own screening tools as well. These are ones that are just suggested. And what we found in the Alberta pilot of the TIP is that most agencies prefer to kind of use their own tools, because they've been working in the field and they have their own tools that they use. There's another section which is at-risk is screening for people that are at risk for having FASD themselves. And this section is a little bit more tricky because there's not really one FASD screening tool that's been validated. We do have a neurobehavioral screening tool published with the Public Health Agency of Canada that has been assessed with children with FASD, but nothing really with adults. So as part of the original TIP, it's more about clinical judgment, about understanding the characteristics of individuals with FASD and whether or not clients may meet that. But what we wanted to do in the Alberta pilot of the TIP is we wanted to have more of an objective tool for screening with FASD. And so we partnered with Dr. Therese Grant, who's at the University of Washington, who actually has recently developed a life history screen for FASD. And Therese Grant is a worldwide expert in FASD and has worked with Anne Streiskath and has over 20 or 30 years of experience in FASD. So she is a great person to develop such a tool. And so we use this life history screen in our Alberta pilot of the TIP. And I'll go into a little bit more detail on what the life history screen is. The 2 there is actually for the reference, and the references are at the end. So if you go to the second reference, you can actually find the reference for the published life history screen. It has been published in a journal. So just keep in mind that this wasn't part of the original US TIP, but we decided to include it in the Alberta pilot of the TIP. So it was added as a potential tool for identifying FASD, but of course we didn't know, we need more research on its efficacy. So the life history screen focuses on, I think it has about 10 questions, and it focuses on several kind of key areas of red flags in a person's life. And this can be done either with the client interview or from retrieving information from the client files as well. So childhood history. So not being raised by biological parents, that's considered a red flag. Maternal alcohol use. Obviously, a huge red flag would be maternal alcohol use during pregnancy, but a lot of times that's not known as an adult. So even if they remember that their mother abused alcohol when they were growing up, that is considered a red flag. And then there's a series of day-to-day behaviors, which is really looking at a history of maladaptation. So trouble making decisions and just kind of functioning in society, a lot of those maladaptive behaviors that we see common in FASD. Education issues, so having not completed high school is another red flag. Having a criminal history, again, red flag, not required, because of course, but is a red flag. Having substance abuse themselves. Having an employment and income issues, not able to keep a job, things like that. Living situation, they look at whether or not they're able to live on their own, how long they've been able to live on their own, how long they've had stable housing. And then, of course, mental health issues, which is a big one. So do they have any mental health diagnoses? Do they have any previous attempted suicides? So the TIP looks at all of these, the life history screen looks at all of these areas. The first three, if they have a red flag in all three, then they could be considered to screen positive on the life history screen, which is indicative of possible FASD, or they could have a red flag in any two of the bottom box and two in the top box, and that would also be considered a red flag. So if they don't have a red flag in all three of the top, as long as they have two red flags here and two here, then that would also be a positive screen on the life history screen. So now I'm going to talk a little bit about the Albertan Canadian TIP project. So it evolved from the USA TIP, which was published, I think, just last year. And Sterling Claren, who was the previous director of Canada FASD Research Network, and who also was involved in the writing of the original TIP with SAMHSA, he brought the TIP to Alberta and said that they wanted to do a kind of a pilot project, and they partnered with the government of Alberta across Ministry Committee on FASD to pilot the TIP here in Alberta. But what they first did is they first modified the TIP to include Alberta and Canadian content, because obviously our service delivery systems are very different than in the States, our process for referrals and diagnosis. So they went through quite a bit of time to modify the TIP to make it appropriate for an Albertan audience. And then we developed training tools and modules. So again, the two components, or the two kind of main screens as part of the TIP, are either you're at risk for having a child with FASD, so that could be a woman who is currently abusing alcohol and pregnant, or it could be somebody who's not using protection and abusing alcohol and of childbearing age. That could be also considered somebody that's kind of more loosely at risk. So anybody that's considered to be at risk for having a child with FASD, here in Alberta we have a wonderful program called the Parent-Child Assistance Program, which is a mentoring-based program for high-risk women. And so many of them could be referred to that program, but they could also be referred to other substance abuse kind of programs as well. It doesn't always have to be the PCAP program. And then, of course, if they're suspected of having FASD, we can look, well, do they already have a diagnosis? Because some of them might, and if they do, then they would have a care plan with an integrative team. If they don't have a diagnosis, then they could be referred for an assessment. And we do have a specific clinic in Alberta, in Edmonton, for diagnosing adults with FASD. And then they could potentially get an FASD diagnosis and then again have a care plan with an integrative team. And if they don't have FASD, they still could be referred possibly for alternate services, especially if they have, a lot of life difficulties and a history of maladaptation. So through CMC, which was a partner with CAN FASD on the pilot of the TIP, they also partnered with Alberta Health Services to identify 3 agencies that were included in the pilot of the TIP. 3 agencies that were dealing with mental health and substance abuse treatment programs. And the TIP pilot ran January to May of 2014. So this is pretty recent data that we have here. It was just ran for 5 months to see how it would work in these programs, because it really was quite a bit that we were asking, or that they were asking programs to do, is to look at the screening of new clients at intake. So the 3 programs were Aventa, which is a program in Calgary for women only with substance abuse issues. Addiction Services here in Edmonton, which serves a wide, male and female, and has a very large population with substance abuse issues. And then Métis Child and Family Services SNUG program here in Edmonton, which is a program, the SNUG program specifically is for street-involved women, and it's to help them get off the street. So that was considered to be kind of more of a higher risk group. All of the programs are already linked to diagnostic centers and for making referrals for an FASD diagnosis. So they all received a half-day workshop training them on FASD and the TIP, and the tools used in the TIP to help identify either women who may be at risk for having a child with FASD or individuals who may themselves have FASD. And then they were asked to screen clients at intake only when there is a suspicion that the client either maybe had FASD or was at risk for having a child with FASD. They weren't asked to screen all clients because that would be a large burden and would take a lot of time. So only ones where there was a suspicion. And then, of course, they were given information on referral pathways and treatment pathways and programs and services that they could then refer clients onto. So as I mentioned, for the pilot, screens were not done on all clients at intake to minimize the burden on the program, which was a positive thing in that it helped reduce their workload. But in the end, our data is not, any pilot data is not true prevalence data, because not everybody was screened in the programs, only those for who they had the suspicion. But of course, because we asked them to only screen those who they had a suspicion for, that could lead to some potential bias that different workers at different programs could have different perceptions on who they felt was at risk. So that's something that we have to keep in mind that could be affecting the results as well. So now I'll hand it over to Katrina, who's going to go over some of the TIP screening results.
So I will talk about the screening results for each of the 3 programs individually, and then sort of do a summary of cross-program data on the results of the FASD screen. So first I'm going to talk about Aventa. So as Carmen mentioned, Aventa is a residential facility for substance abuse treatment for women only in Calgary. Most of the participants were drawn from a program called Phase 2, which is a 6-week residential treatment program. As you can see, these are sort of the characteristics of the sample that we collected data from, which was 74 individuals, average age of about 30. 7 women, so about 10% of the women screened were currently pregnant, which is of course of concern since this is a substance abuse treatment facility, which I would infer could mean that these pregnancies are potentially exposed. Most of the women were currently unemployed, and about half had not graduated high school. So Aventa saw 114 clients during this time frame from January to May, and they screened 82 of them. But then 8 were subsequently excluded. So Aventa excluded participants who had an IUD, who had a hysterectomy, or who were over 49 years of age. And then we additionally excluded 3 participants because they had the staff at Aventa had indicated the participants were screened, but then there was no screening result included, so we didn't know if they had screened positive or negative. So of this, we had 74 valid screens, and so that's about 65% of the total number of clients seen at that time. So I'm just going to take you through the results. They're a little bit confusing, but I have them separated by first the screen for women at risk of giving birth to a child with FASD, and then second will be screening for those suspected of having FASD themselves. So first, Aventa screened 100% of the screens they did were for women at risk of giving birth to a child with FASD, which they really more loosely define, and this is really common in prevention literature, to define women being at risk of giving birth to a child with FASD if they are of childbearing age and if they're consuming alcohol. So that was basically their criteria. So almost about 65% of the total clients seen at that time were screened for being at risk. 97.3% did screen positive as being at risk of giving birth to a child with FASD, which is of course quite high, and these are women receiving treatment. When asked if they wanted help, 4 of the 72 who screened positive said no, which is generally either they weren't interested or they had more pressing needs at the time. But the overwhelming majority did say yes and received referrals for help, and referrals were made to further programs within Aventa. And then only 2 clients of the 74 screened negative for being at risk of giving birth to a child with FASD. Aventa only screened 2 of their clients for being suspected of FASD, so quite a small sample. These 2 women were also both screened for being at risk of giving birth to a child with FASD. However, Aventa did have 4 clients who already had FASD diagnoses. They did not additionally screen these clients with an at-risk of FASD, at-risk of FASD tool, which could have been nice, but we left it up to the sites to determine whether or not they would screen. But one thing, if they would have screened these clients who did have diagnoses already, would have told us is that is someone with a diagnosis going to screen positive on this instrument, and it would be a way of sort of confirming whether or not we're getting a lot of true positives. But of the 2 they did screen, they both screened positive, and only one did not want help and one did want help, and they were referred to an adult FASD clinic. And obviously 0% screen negative. Moving on to addiction services, which is a branch of Alberta Health Services. Data was collected from several sites within Edmonton, Sherwood Parks, and Alberta area. And both male and female clients were seen, so very different demographic from the individuals seen at Aventa. So you can see much more males were seen here. Almost 70 or 71% of the individuals seen were male, and they screened a total of 76 individuals. The average age was a bit higher, and of the 22 women they screened, 1 was currently pregnant. During this time, Addiction Services did see a lot more clients than Aventa did, so they saw 845 new clients, and chose to screen 76 of those clients. So 9% of the new clients were screened. So first, for individuals at risk of having a child with FASD, so this is only the women. Men were not screened to be at risk of having a child with FASD. So of the 22 women that were seen, 12 were screened, so just over half, and that's 1.4% of the total clients seen at that time. Of the 12 screened, 2 were screened to be at risk of having a child with FASD, so it means they had concerning alcohol use. And both of them did want help and were referred to further substance abuse treatment help. And then 10 screened no. For those suspected of having FASD, they did screen a lot more than Aventa did. They screened 73 individuals, so almost all of the clients they did screen at that time were screened for FASD, and 11 were screen positive, so about 1.3% of the total clients they saw at that time, which of course is very similar to current prevalence estimates of FASD being about 1 to 5%. Again, 3 individuals that they saw at this time did have confirmed FASD diagnoses, and they did not deliver the FASD screen to them. Of those who did screen positive, 8 did not want help. Again, either they weren't interested or they had other pressing needs. 3 did want help and were referred on to the FASD, adult FASD diagnostic clinic. And then there's a proportion of clients where we were unsure of the result here. So they did do the screening tool and they did check off red flags, but ultimately it kind of comes down to clinician judgment whether or not you're going to say someone screens positive or negative. And so they just ended up not really saying whether or not they thought it was positive or negative. So we did not make that inference for them when we looked at the data. And then the majority did not screen positive for FASD, so about 75% of those screened for FASD did not screen positive. Moving on to the SNUG program at Métis Child and Family Services. Again, this is a program in Edmonton, Alberta, and it's a community outreach program for women living on the streets. So this is a very high-risk group, and this program, I think it was a lot more difficult for them to engage in screening with their clients because their clients don't necessarily come into an office to chat or do therapy with them. It's a lot of street outreach work. You may not have consistent client contact. You may only see someone for 5 minutes at a time, and you may be spending most of your time with that client trying to, get them food stamps or find them secure housing for the night or something like that, not necessarily screening about their alcohol use. So the majority of these women were engaged in prostitution as their employment. And the average age was about 36 years old, but ranged from a young adult to about 51 years old. And these women did have more children than seen in the other 2 groups that we worked with. So another, as I said, a difficulty with this program is it was, again, difficult for them to figure out how many clients they were seeing at that time. And the reason why it's important for us to know the number of clients these programs saw at a given time was sort of to determine if the rates of screening that we're seeing in these, sort of, I guess, to contextualize the rates of screening we're seeing in these populations. So they estimated they saw 25 new clients during that time period, but they don't know the total number of clients they engaged in contact with in that time period. But they did complete 27 screens, and 13 were with new clients. So about half of new clients were screened, and then 13 were with current clients. So at SNUG, those screened at risk for having a child with FASD, they just screened 1 individual. Their screening criteria was obviously a lot different than a place like Aventa, who screened all of their women. At SNUG, I think they just screened based on whether they thought the woman was pregnant or was at high risk of becoming pregnant. So 1 was screened positive. She did want help and was referred onward, and 0 screened negative. And then for suspected FASD, SNUG screened all of the screens that they conducted were FASD screens, and nearly half of the screens they did screen positive. And 2 of these individuals did have FASD diagnoses. So sort of different from what Aventa and Addiction Services did, SNUG also screened people who had disclosed that they did have a previous FASD diagnosis with the FASD screening tool, and these individuals did screen positive. 4 of the individuals did not want help. In this program, it was not necessarily because they didn't want help, but it was because they did have a lot of really pressing needs that they needed to address, such as secure housing or safety concerns or health concerns. 4 did want help and were referred for an assessment. The other 4, it was not disclosed whether or not they wanted help. And again, this was another instance where the screening tool was filled out, but we weren't necessarily sure of what the service provider thought the result of the screen should be. So about a quarter of those screened, we weren't sure of the result. And then 8 individuals, or about 30%, screen negative. So just to summarize some of the data on the FASD screens. So across the 3 programs, we had 986 individuals screened, and just over 100 of them were screened for FASD. And as I said, SNUG screened 100% of their clients. So of these 102 individuals screened for FASD, about a quarter screened positive. so about 24.5%, or about 25 clients. And of these individuals screened, 6 had previous diagnoses of FASD but weren't screened with the screening tool. So that equals about 3% of all clients flagged as having suspected FASD, which is again quite in line with current prevalence rates, at least in children. Of the approximately quarter of individuals who screened positive for FASD, 8 were referred on for assessment. And the rest, as I have said a couple of times, either had more pressing health concerns or were just not interested in assessment at that point. Just to quickly get into some characteristics of those who did screen positive, those who did screen positive for FASD tended to have less education than those who screened negative. So about 93% of the FASD positive group had not graduated high school compared to 34% of the FASD negative group, which could make sense since one of the questions on the FASD screening tool is one of the red flags is lowered education or failure to complete schooling. Individuals who screened positive also were more likely to be female. However, 2 programs were only for women. But if you look in addiction services, which sees both men and women, they screened 69 clients for FASD. And of these clients, 57% of the positive screens were female. And of the female screened for FASD, 58% were positive versus 11% of the males screened for FASD. So this sort of relationship still seemed to hold true even in programs that screened mainly men. That's what I said. Individuals who screened positive for FASD also tended to be younger, so they had an average age of about 33 years old versus those who screened negative, who had an average age of about 40. And then individuals who screened positive for FASD also tended to have more children. So those who screened positive had an average of about 2 children, whereas those who screened negative had about an average of 1 child. So just to kind of conclude this section on screening, what was really cool about this is that even though we didn't get to screen all clients, that a lot of clients, including those who had never been previously identified as being suspected of having FASD, were identified as being potential, having potential FASD diagnoses, and referral pathways were initiated for some. So we possibly caught some people who maybe weren't receiving supports and services for difficulties they were having associated with prenatal alcohol exposure. The 3% positive screen rate may be an underestimation since we did not screen everyone. If we screen more people, you might expect that the rate of positive screen may actually go up. And this was, of course, related to service providers using their clinical judgment to only screen those that they suspected of FASD. And, of course, there's nothing wrong with that, but the judgment of that can differ between different people based on your experience or your opinions about how things work. So it's very subjective. We may have missed some cases, which, of course, ties into if we may have had a higher positive screen rate, and we may have caught more of these if all clients were screened. And we would need to have more data to see if some of the relationships or characteristics of those who screen positive tend to hold up, and especially the sort of gender bias where more women tend to screen positive than men. That relationship was more trending towards a significant relationship. And of course, we had a lot more women seen than men. So we need more research, especially with that. And we also don't really have data from mental health programs in the pilot. We mainly focused on substance abuse treatment and the SNUG program, which was had a street outreach focus, but no real program that focuses on mental health care. And it would be really important to screen in these settings, particularly if we consider that in some studies, 90% of individuals with FASD do experience mental health concerns, and a great proportion of these have experienced inpatient care for mental health concerns. So I'm going to turn this back over to Carmen to discuss the results of our service provider survey, which was a survey we gave to individuals at all of the sites that we worked with. It was an optional survey that they could choose to fill out or not on the internet, and just tried to get some of their perspectives on how it was to use the TIP.
Thanks, Katrina. Okay, so I'll go over some of the results from this survey that we did with the we developed an online survey for service providers who participated in the TIP pilot. So any of the programs and their workers that used the TIP were asked to do the survey. It wasn't required. It was completely voluntary, and it was completely anonymous. It was done online. We wanted to get information on their experiences using the TIP and some of their perceived strengths and weaknesses of the TIP, because this really was the first kind of pilot of the TIP. We had 14 service providers complete the survey across the 3 agencies, so we had a relatively low participation rate. So we'll only look at data aggregated across the 3 agencies because the sample sizes are too small to separate it by agency. It was a very quick survey. It was probably 5 or 10 minutes to complete. So the first question was just that the TIP was easy to use, and as you can see, they had a 5-point Likert scale that they could answer on. And the majority either agreed or strongly disagreed. We just still had a neutral voice that either kind of agreed or neither agreed or disagreed. For the second question, the TIP was easy to understand. Quite a few agreed and strongly disagreed, but we had a lot that kind of were still in the middle. And that tells us that the TIP needs to be we need to do a better job on explaining the TIP and the process and the referral process, because it is quite complex. And, you know, people came in for a half-day workshop on the TIP, and maybe that wasn't enough. Maybe, you know, there was more training needed. There also was consultation available to any of the service providers throughout the whole process of doing the TIP, for the research side and the clinical side as well. But still, many, you know, over 40% kind of neither disagreed or agreed with that. So we still need to do a better job there, I think. After using the TIP, over half agreed or strongly agreed that, so these are just separated by question now, and the bars represent the percent that either agreed or strongly agreed. So over half that their knowledge of FASD has increased, so that's good. Many of the programs were already very knowledgeable of FASD. They were more aware of referrals and resources for at-risk clients. That was only just about 30%. So still 70% felt that they were already pretty aware of the services and referral pathways. Whether or not they were more aware of referrals and resources for those suspected of having FASD, about 50% felt that they were more aware of that. Less than 20% actually felt that it actually improved their client care, and that probably is related to the fact that they didn't do anything with the screening results. They were always referred on to a different program or resource, so that could be the reason for that. Over 40% felt that they learned useful information beyond what they already knew. A lot of these programs had individuals that had received FASD training before and that were quite knowledgeable about it already. And about 50% felt they were pretty confident making FASD referrals. So we would like to see that number increased. We would like to see everybody being confident making FASD referrals. So that's something that needs to be worked on as well. Some of the strengths of the TIP. So 50% of the clients felt that it gave them additional information and insights about their clients. Whether or not it provided a procedure for them to follow, 36% felt that. If it improved their referral process, 14% felt that. I think many individuals may have already been referring to other programs, so we would like to improve that number. There was other strengths that were reported by 21%. 14 felt that there were no strengths. And then the last two, we didn't, this was, people could click off the boxes for this question. They didn't feel that it helped making their practice more efficient, or it increased their effectiveness in working with clients. And that was kind of a barrier that we saw, is that having to do kind of the screening may have actually affected the worker-client relationship. So that's something that needs to be worked on as well. Some of the weaknesses of the TIP, 50% felt that the process took too long. 50% felt that it negatively affected client service provider rapport, and that's an important point to take home. We didn't require that, or it wasn't required that they did the screening on the first initial visit with the client. You know, we did say that they could wait, for a couple of visits to kind of build that rapport, but they still felt that it was affecting that, and that's an important thing that needs to be taken into consideration. Some of them, reported other weaknesses. 28% felt that it just wasn't a top priority for their clients, and that's fair enough. Some felt that certain parts took too long, maybe not other parts. 21% felt that it wasn't relevant to their caseload, so maybe they weren't seeing a lot of clients that kind of met these criteria. 7% felt that the TIP didn't ask the right questions. 7% felt that there were no weaknesses to the TIP. That means that many of them still felt there were some weaknesses. But 0% said that it did not add useful information to their practice. So that still was a positive finding. So based on the survey results, we still have, I think that there still needs to be more modifications to the TIP and the process that screening is done. The pilot stopped in May. But the TIP is a program. It's really, in the States, it's kind of seen as a change in guidelines for how service providers work. So I think that doing the pilot is really important because we got great pilot data and we saw a lot of positive screens, but we also got important data on the service providers' opinions using the TIP. It's also important to keep in mind that only 14 service providers filled out the survey, so we didn't get the full perception of everybody. So in discussion, obviously early identification of at-risk women is really important for reducing the incidence of FASD. It's important for FASD prevention. We know that FASD has a huge cost to society, so even preventing one case of FASD has a huge monetary savings to society. It's very important. We also identified potential cases of FASD that were not previously diagnosed. And this is important because we have 8 individuals that were not on the radar in these programs for potentially having FASD that are now have been referred for an assessment. We do plan to do further follow-up to see how many of those individuals actually went to their assessment and how many actually got a diagnosis. Because wait lists are quite long, we do have to wait for that kind of process to unfold. And there were still a lot of other individuals who were screened for potentially having FASD who did not want a diagnosis, and that's still important to know that those individuals are at risk, but they didn't want to go for a diagnosis at that time. So the referral pathways were initiated for some clients, which is really important. And we do know that receiving an FASD diagnosis, receiving a diagnosis in an earlier assessment is a protective factor against many adverse outcomes in FASD. So even if just a few individuals can be connected with a diagnostic program and get a diagnosis and then receive those services and supports with, wraparound services and supports that can help them function in society, that could in turn reduce a lot of the adverse outcomes we see in FASD, like trouble with the law, substance abuse, not being able to hold a job, and potentially even help with mental health issues that could be identified at a diagnosis. So I think there also is a huge savings to society there with improved screening and better diagnosis. We can better connect individuals with the services that they need. The pilot also shows us that screening in substance abuse and mental health treatment settings is feasible, but right now the process isn't perfect and it needs to be worked on and improved as well. It definitely is probably a little bit more difficult to implement in kind of more street outreach programs with higher risk populations. And we also have to consider, balancing using these screening tools with kind of overall clinical judgment on whether or not an individual would screen positive as well. So what are we doing from here? We're still analyzing data. We're running some data analysis yesterday, further data analysis on this project. There still is quite a bit of data. We want to consolidate what we've learned from the Alberta pilot of the TIP, including this perspective from service providers. We did have an option in the survey that if they wanted to also participate in a detailed interview on their use of the TIP that they could, but nobody opted for that option, and that's completely fine. These individuals are very busy. They already took the time to fill out the survey, but we thought, if we could get some qualitative data in an interview format, that would be great, but people didn't sign up for that, so that's fine. But we still need to do further gathering of information and just kind of bringing the information together to kind of decide where things will go next. This information could potentially be used for training other programs and providers on the TIP. Like I said, the TIP is really changes in programming, so kind of decide what is the best way to proceed in training other agencies and supports. And so the overall TIP in Canada is really housed with FASD Research Network, and they're the ones that are kind of the decision makers behind it, as well as partnering with CMC on the pilot. We need to look at the pathways that clients use to access assessments and intervention and any obstacles that they may face. So I think that's another really important research question to come out of this, is to do another study further following up adults with FASD to gain insight into how the FASD assessment and diagnosis process works for them. And there could be obstacles within that process as well. One of them may be long wait lists. There could be a lot of other things happening. Also to look at evaluation of clients and the impact of a new FASD informs lens, how that this has on their assessment and subsequent treatment plans. So what does it mean for an adult to get an FASD diagnosis, and what does this mean for them in their life? So I think we'll open it up to questions there. We've ended pretty good for time. I don't know if we talked really fast or we just kind of, because we did have quite a bit of slides, so we have plenty of time for questions. So should we open it up to the, okay.
Carmen, I'm very interested in the phenomenon that there was no difference. None of the service providers identified a difference in their practice with the use of the tool.
Yeah, and it's hard to, I'm trying to see which question was that?
That was part of the results that you got from the service provider survey.
So I think some did report a difference. But still, we had many that kind of had a neutral voice or didn't report. Mm-hmm. Yeah.
Mm-hmm. And I wonder if there's a link between the belief that it's not making a difference and the fact that they actually do the screening in the first place. If they're not expecting the screen to make a difference in the way they can be effective with their client, mm-hmm. then they won't see the value in screening.
Yeah.
And if they are going to expect to have to refer that client to another source for services, if they screen positively, they may be less likely to screen, because some of the services that you've identified are set up for intensive, longer-term treatment, mm-hmm. and so it would be disruptive mm-hmm. to their relationship with their client.
To refer them out.
So the incentive to do the screening mm-hmm. is pretty significantly reduced if there's no advantage to the relationship between the service provider and the client. Mm-hmm. And you know, and this ties into research that you see over and over again, that the biggest challenge in implementing a new practice is the practitioner themselves, mm-hmm. and the change that requires. Mm-hmm. Mm-hmm. So I'm wondering if you could comment on what you think could be done about that.
Mm-hmm. Yeah, those are really good points. I think that so on the positive side, a lot of the practitioners felt that their knowledge of FASD and referral, specifically of FASD, had increased, which is a good thing, because we really wanted to kind of change a lot of their mindset about just kind of having it on their radar to screen for FASD. But it's equally important that they think that the outcome is important, and that referring to external sources is important. And we didn't have any questions really directed at that on the survey. And that is something we could follow up with as well, because I do think it is important. And I think that in further training and further use of the TIP, we really need to have practitioner and service provider buy-in, and to understand the importance of other services that are available to support individuals, or the importance of a diagnosis or early assessment. I completely agree. It turned out, like at Aventa, I think they only referred a couple of people to a PCAP type program who were the very high risk individuals. The other individuals, the treatment pathway was their program. They're a substance abuse program, so they actually didn't refer them out. They were in their they were in their inpatient substance abuse program. So for some of them, it didn't mean referring out. For the FASD diagnosis, it always means referring out. And then it's kind of like that black hole that they're referred out, and it's kind of like they don't know for sure what's going to happen. They're not necessarily a social worker working with that person that is going to take them to their diagnosis. So I kind of feel that many of them maybe felt that they kind of had this process and then they didn't really know what happened. And I think that's where we need to improve things as well. Mm-hmm.
Who administers that?
So that's CMC. That's with the government of Alberta Cross Ministry Committee on. Yeah. So it's the Parent-Child Assistance Program. It was developed. That program was also developed by Therese Grant in Washington at the University of Washington, who also developed the life history screen. And it's been there's actually been quite a bit of rigorous research on the PCAP program. It's been shown to be very effective in Washington, in the States, and in Alberta, actually. So, but that's for the highest risk women. Not all women would be appropriate for that program.
I have another question. What do you make of what appears to be a gender difference in the frequency, in the rate of FASD?
Yeah,
that was pretty interesting.
It was interesting. So when you look at everybody, there were more women who screened positive, but then, a couple of the programs were only for women. So we looked only at addiction services. The problem with addiction services is that, yes, 57% of the positive screens were female, but they only screened 14 women out of the 69 screens. So the actual number of women that they screened out of the 69 was actually lower. So when we looked at, of the females that were screened, 18 women were screened. 8 of the 18 were positive, versus 6 out of the 51 males. So basically, this creates a much higher percentage for the FASD group, but there were more males overall screened, but when they were screened, they were more likely to screen negative. So it was an interesting finding. Because we still had only 18 women that were screened there, it could just be related to numbers. If we did have more women, we might see that effect wash out. But it may actually be something that's holding true. It could be perhaps that males with FASD show more difficulties earlier on, and or maybe identified for other services and supports earlier on. I'm not sure. This was also only focusing on substance abuse, not the mental health side. So we may see a different trend if we were focusing on agencies that only dealt with mental health issues, but it's definitely something that we need to look into further, because it was pretty interesting. And the difference that 58% of the females were positive versus 11% of the males, it is still a pretty big difference. So yeah, I don't know if you have any ideas of.
Well, I'm just wondering if there's any potential that there's a cultural bias there, and the way that either the questions are posed, or the way the questions are interpreted, mm-hmm. or what it is that we are, unconsciously expecting in terms of female versus male behavior,
yeah,
and what we tolerate on either side.
Yeah, so that could have played a role, and we just we can only make inferences at this point, but it was really interesting, and we need to really think more about it, about what could be happening there. Maybe if we had a larger sample size, the effect could wash out, but who knows?
So thank you both for a great presentation. It was very informative and interesting, really fascinating research you've done. Just to a note for everybody, evaluations will be emailed to participants within the next 2 business days. So please be sure to sign the attendance sheet. Your feedback for this session is very valuable to us. And please join us for our next presentation on January 21st, when Hazel Mitchell and Lisa Rogozinski will discuss the Prevention Conversation Project.